Man, woman, birth, death, infinity.
Good afternoon, and welcome to the Your Health radio and television program on the radio at AM 1240 KNRY, AMP's cable television channel 24, and on the web at www.ampmedia.org. Join our rotating host and their informative guests live every Monday afternoon at 4 o'clock. The purpose of the Your Health radio and television program is to help get, make, and keep listeners and viewers like you healthy. And now, ladies and gentlemen, on with the program.
Hello, I'm Dr. David Morwood. I'm a board-certified plastic surgeon, and this is Your Health radio and television program. Thanks very much for joining us. And my very special guest today, Dr. Christopher Barnard, dermatologist. Dr. Barnard, thanks very much for being here.
Well, thank you for inviting me.
Our assignment for the next 18 or 20 minutes or so is to educate the listeners and viewers of this program about skin cancer. But before we do that, let's talk a little bit about what a dermatologist does. Dr. Barnard, what's your average week like? What do you do in the office?
Well, it's a 5-day week. We start 8 o'clock in the morning and see patients pretty much through till 5 o'clock. And a typical day is pretty much exams and procedures. The exams involve looking over the entire body surface area for skin cancers primarily. But many patients come in for other things that they're asking about, rashes, that sort of thing. When we do find a skin cancer or a suspicious lesion, we often do a biopsy, skin biopsy, very simple procedure, and then send that off for pathology. If that is indeed a skin cancer, we'll have the patient come back and remove that skin cancer.
Okay, so that's real important stuff, and I want to get back to that. But before we get to that, a dermatologist essentially is a skin doctor.
Right.
So, and I know there's some dermatologists that specialize in nothing but children's skin diseases or specialize in infections, and some doctors, skin doctors or dermatologists, specialize in skin cancers. So you're a board-certified dermatologist.
That's right.
So Dr. Barnard, tell us what it's like. Let's say we have a high school student who's listening or watching. What does it take to become a board-certified dermatologist?
Okay. Of course, completing college and going through 4 years of medical school.
So that's after high school, 4 years of college,
Right.
and then 4 years of medical school.
Right.
And then what?
Then applying to a residency in dermatology, but that has to be followed. First, you have to do an internship in either internal medicine, general surgery, or pediatrics. That's just a single year. You can do the whole 3 years of any of those, but then typically you'll go on to dermatology residency, which is 3 more years. So it's about 4 more years of training after medical school.
So after 4 years of college and 4 years of medical school and then 4 years of internship and residency, you get to be a dermatologist.
Right, and then you have to be a board-certified dermatologist. You also have to take a rather rigorous exam at the end of your training. And so the majority of dermatologists are board-certified.
Right. So Dr. Barnard, we might say that surgeons need to be good with their hands, and they need to have good eyes, of course, and certain times they need to get up in the middle of the night. So what might we tell medical students, like who is it that goes into dermatology? Like who makes a good dermatologist?
Someone who has a very visual memory. That would make a great dermatologist. Someone who really recognizes patterns and has a fantastic memory for learning a tremendous amount of information. There's almost 1,000 skin disorders. So to know all of those and be an expert on every single one takes a lot of study, and of course someone who's very, very particular about tiny details.
I understand. So Dr. Barnard, again, so you're a board-certified dermatologist and you practice here in Monterey.
Mm-hmm.
So one of your important functions for the community is to do skin cancer screening. So I'd like to spend the majority of this 20 minutes talking about skin cancer. Mm-hmm. Let's start off, if we may, by talking about, well, let's define, what is skin cancer, really?
Well, there are 3 main skin cancers. There are others, but the most common by far is something called basal cell carcinoma. The next is squamous cell carcinoma, and of course the most important is melanoma. Of all of the cancers in the United States every year, there's about 1.3 million new skin cancers every year. That's about half of all cancer. By far the majority are basal cells, and those are typically a round or pearly shaped growth on the skin. It may bleed, it may not bleed. There are actually 5 types of basal cells.
Okay, so we can say that there's 3 common types of skin cancer: basal cell skin cancer, squamous cell, and melanoma. Now, do they share a common cause, or how is it that somebody gets skin cancer?
Right. The ultraviolet light, sunlight, by far is the most important cause of basal cell and squamous cell carcinoma. Family history or inherited factors are probably one of the biggest factors for melanoma. Although ultraviolet light and solar radiation is a very important factor in melanoma as well. So sun protection is key to preventing the development of skin cancer.
Okay. Well, Chris, you know, in general, when someone hears that they got a diagnosis of cancer of any kind, I mean, it's a tough day for them. They're troubled and frustrated and worried. If someone gets skin cancer, is that an automatic, does that automatically mean their life is shortened, or?
Not necessarily at all. The earlier it's diagnosed, the better, certainly. The majority of basal cells and squamous cells, 95%, are cured if they're caught early. That can be true for melanoma if, in fact, with the earliest stage of melanoma, it's quite curable, 99% cure rate in the earliest stage. So surveillance and early detection are really the keys to a good outcome. But the majority, by far, melanoma is the most worrisome skin cancer.
Okay, so you mentioned something, I think there was a really key phrase, surveillance and being monitored. Now, I think one of the most important functions we can play today is to educate our listening and viewing audience about signs of skin cancer, right? So what does someone look for? Maybe we can kind of break this up into categories. There's basal cell and squamous cell and melanoma. But let's start with basal cell. Let's say someone has a history of heavy sun exposure. They used to lay on the beach a lot, or they're a farmer, or they worked outside for years. What should they look for to be concerned, or what can they examine their own skin for signs of basal cell carcinoma?
Okay. I'll give you briefly. The 5 main types are nodular, superficial, micronodular, morphic, and infiltrating. Nodular is the top one. That's the most common. Fortunately, it's one of the less aggressive, like superficial types. The thing that you want to look for in a nodular basal cell, usually that's on the head and neck area, sometimes on the dorsal hand, sun-exposed areas primarily.
Okay, so I think that's key. Let's emphasize that. So most basal cell skin cancers come on sun-exposed areas, the face, maybe the neck, the shoulders, and the backs of the hands.
Right.
Okay, so what do people look for?
Right. The common finding would be a little raised, shiny, or pearly, or waxy appearing little bump. Could be pink, could be red, it could be something that easily bleeds, possibly. Something that even gets a little ulcer or a crust that won't go away. That's a nodular type.
Okay.
The superficial type is more difficult because it just looks like a little scaly pink patch, and that may be more on the trunk, actually.
Okay. Now, this is very important, but I want to ask another question, if I may. So let's say somebody has a history of heavy sun exposure. Does that mean they see you once a year? Should they get screened by their family doctor, their internist? Should they make an appointment to see a dermatologist? Like, what's the rule about surveying the general population?
Well, it depends on your family history. It depends on your history of sun exposure. And in general, I encourage everyone to have a primary doctor, of course. And so they can certainly do an initial screen. If there's any family history, particularly of melanoma, they should definitely be seen by a dermatologist. And if they have any suspicious lesions that they really are concerned about, then they should ask for their primary care doctor, internist, or family doctor to refer them to a dermatologist for an exam. If a particular lesion or a spot is bothersome to the patient, I think going straight to the dermatologist is probably the best idea, the most efficient way of finding out what's going on.
Okay, so now, so for the signs that someone would look for a basal cell carcinoma might be a lesion that doesn't heal, a raised area on their face or shoulders or neck or back of the hands, just something that doesn't go away and they're concerned about.
Right.
Okay, So how about squamous cell carcinoma?
Squamous cell is usually a little faster growing than basal cell, and it may be that's typically more actually on the back of the hand. That's like the ratio is probably higher for squamous cell than basal cell. Same thing, sun-exposed areas. The ears are a common location for squamous cell. The lips are actually another spot that squamous cell shows up. But a crusted lesion that will not heal, and that actually may be growing a little bit faster, and that typically gets most people's attention.
Okay, so what I heard, now correct me if I'm wrong or tell me if I'm right, if a patient, the average person sees a lesion that just doesn't heal and seems to grow and is kind of crusty, it sounds to me like that's a sign to call the family doctor or see the dermatologist. Is that right?
Absolutely. Something that's not healing should definitely be examined. That's right.
Okay, so we talked about basal cell carcinoma briefly and squamous cell. Now, this idea of melanoma, I mean, just to get a diagnosis of melanoma scares people. So what is it about melanoma that seems so startling?
Well, of all of the skin cancers, melanoma is the most deadly by far. Of those 1.3 million new cases every year, about 100,000 will be melanoma. Of those, about 10,000 new cases of melanoma each year are deadly. And so by far it's the one that causes the most death of all the skin cancers. So you want to, but if you catch it early, it is curable. So the key is to identify those findings early on so they can be removed and have a great outcome. The findings for melanoma are, there's a nice mnemonic, I brought a little brochure here, of the ABCDEs of melanoma. So a mole that's changing is the key.
Okay. Now, once again, so for our listening and viewing public, a mole that changes, say like could grow or turn a color or may bleed or just grow larger, that's a sign to get on the phone and call your doctor.
Then you should go right to a dermatologist. That's right.
So is that the only sign of a melanoma, say a changing mole?
Well, the ABCDs is a mnemonic that's been developed to help to basically apply these rules to a mole. A is for asymmetry. So if you look at a mole, it's not perfectly round or not perfectly oval, but if you cut it right down the middle and one half is very different from the other, that's asymmetry. Border irregularity, if there's notching or fading or you can't see a good sharp demarcation between the edge of the mole and normal surrounding skin, that's an irregular feature. Color variegation is multiple shades of brown or tan within the same mole. It could be white, could be red, could be blue, any color change in a mole. Diameter, if it's getting wider, and that's key. And evolution, which is any other change that really doesn't fit nicely into those four. Could be bleeding, could be itching, could be a raised up area. But the benefit, melanoma gives us a warning sign, and that's what's called the radial growth phase. So it expands sideways first before it descends. And in that early stage, before it's broken through to the deeper part of the skin, it's really it's about 99% cure rate with that.
Excellent. So that sounds to me like a real take-home message for, once again, for the public. If they see a lesion that doesn't seem to heal, if they see something on their face or lips or ears or hands that's kind of crusty and won't go away, or a changing, bleeding mole that looks unusual, those are signs that they at least need to be checked.
That's right.
Now, it doesn't mean necessarily that they have skin cancer, but they need to be checked.
Absolutely. Like I mentioned earlier, family history is really key with melanoma. If you come from a family who has a parent, a brother or sister, or if you have a child that's had a melanoma, it significantly increases the risk of developing melanoma in that individual. If you have a lot of moles, that's another risk factor. Fair skin, blue eyes, blonde or red hair, lots of freckling, a history of 2 or more significant sunburns before age 18. Those are all, that stratifies the risk. And so those individuals really should get a head-to-toe full skin mole check.
Dr. Barnard, now that's very interesting. Now you said 2 or more significant sunburn episodes before age 18.
Right.
That increases your risk of melanoma.
Yes, it does.
Well, that's fascinating to me. So it sounds like lots of sun exposure, bad sunburns, increases your risk.
There's no question about it.
Okay, great. So I think, thank you very much. I think those are really key take-home points for the audience. Now, Let's say a person comes into your office. There's a couple key phrases that we want people to know about. Tell us, what is a biopsy? What's that mean?
Well, a biopsy is very simple. It involves taking a small sample of skin, usually a little core, that's the best way to get this, or if you need to maybe take a little tiny excision around a mole. But to biopsy a mole, basically it's numbing it up with a little local anesthetic, and there's very little pain associated with that. Taking that sample, sending that sample off to a pathologist, and that could have been a dermatologist who's specially trained in examining skin, and then having a report that says this is a mole that is okay, or it's a mole that's a little bit irregular, or moderately irregular, or severely irregular, or it is a true melanoma, or it's a basal cell or a squamous cell. And that's step one.
I know that's the time, certainly in my practice, when the patient's at home, sometimes sitting on the edge of their chair, they're afraid every time the phone rings. But I think it's a vital part of getting taken care of is to get a biopsy, right? Now, just because they get a biopsy doesn't mean it's a cancer.
That's right. In fact, probably the ratio of biopsies to true melanoma is about 19-to-1 when it comes nationally in this country. There are many, many grades of moles that are not melanomas but are irregular and important to still biopsy. So just the fact that you're having a biopsy doesn't mean that it's a cancer. It's just suspicious enough to warrant finding out.
Okay, so the tissue is sent to the pathologist and it's examined under the microscope, and we can get an answer if it's a benign or malignant or pre-malignant, etc. Okay, now I know, Dr. Barnard, we could spend hours talking about the treatment of skin cancers, of melanoma alone, or basal cell or squamous cell. But can you give us a summary of how you treat skin cancer?
Well, the most common by far is basal cell. So the treatment options, depending on the type, if it was the superficial type, it can be treated actually with a cream today. There are a couple of ways that work very well. Topical chemotherapy, an immune response modifier, curetting can be done for that superficial type. Excision is usually done for all the rest. So the idea is to go ahead and remove the tumor, send it in, make sure the margins are all clear, and that's a cure. There's another technique called Mohs micrographic surgery for particularly invasive tumors or more aggressive tumors, or somewhere around the eyelid area, or some areas that are more difficult to have to be cleared. That's a frozen section technique where small steps are removed at a time, and then the repair is done after that. That's true for squamous cell carcinoma. The earliest stage can be curetted. And it can also be excised. Mohs is also done very frequently for squamous cell. For melanoma, surgery is always the first step, especially on the earliest stage, because that's all that's required, really. So a simple margin of about 1/2 centimeter for a very early lesion, maybe 1 centimeter for something that's a little bit more invasive, and then up to 2 centimeters depending on the depth of the tumor. If you have a more invasive melanoma that has gone on and then metastasized, and that's the difference between the three. Basal cell rarely ever metastasizes. It's a very locally destructive tumor if it's not treated, but squamous cell and melanoma both can move to the lymph nodes and then onto other organs.
I see. Well, Dr. Barnard, it sounds like treatment of skin cancer, of course, is a whole other topic we could talk for 4 hours. But what I do want to make sure we do before we go on to the next segment is tell people how they can contact you if they're suspicious. Now, you're here in Monterey, Christopher Barnard, dermatologist, and you're at 648-8005.
That's right.
So as we go on to the next segment, can we just summarize again clinical signs of skin cancer, whether it's basal cell or squamous cell or melanoma?
Right. For basal cell, head and neck areas are the most common by far. A pearly or shiny, waxy appearing bump is by far the most common type of basal cell, although they can also crust as well. A non-healing wound is a typical sign, or not a wound, but a growth that won't heal is typical of a squamous cell, more rapidly growing, more on the ears, lips, backs of the hands, anywhere on the face or head or neck also. And then for melanoma, it would be a pigmented, a brown spot, a mole that's either changing, or the appearance of a new mole that was never there before that has any of those features of the A, B, C, D, E. So any changing mole, that's by far the most important information.
Okay. Dr. Christopher Barnard, dermatologist, board certified here in Monterey. I sure appreciate you coming on and on the program and educating our listeners and viewers. Thanks very much.
Thank you.
I'm Dr. David Morwood. I'm a board certified plastic surgeon. This is Your Health radio and television program. We're going to come right back, so please stay with us. Thank you very much.